and injections. I usually don't use injections early on, but later you can get some benefit from steroids. There's been some evidence that stem cells can help as well. Botox is a emerging technique for this. And what I'm seeing is it doesn't really matter what you're injecting in there, it's just that you're injecting something. So there are actually studies showing that just injecting saline into the fascia causes this relief of pain. And they're looking into why that is. We don't really understand why that is. It's basically relief of substance P, and it's a diminishment of the fascia tightness because you're making small cuts in the fascia. And then you're also creating an acute injury, so you throw it back into the acute phase, and then you can treat it as an inflammatory condition again. But it really highlights how little we know about this condition, that so many things seem to work. In addition to one is shockwave therapy. That's really an emerging technique that's still an out-of-pocket expense, but it can help. We can release this, we can do an open versus an endoscopic, or even a gastrocnemius release because of that connection between the Achilles tendon and the heel. Up here is called a Strassburg sock. It's kind of the alternative to a bulky nighttime extension splint. Sometimes in my very recalcitrant cases I'll use something like that, but it is not well tolerated usually. This is showing a nice stretch against the tree. That's with a bent knee, that's getting the soleus muscle. If you straighten out the knee, that's the gastrocnemius. Those are the two major muscles that make up the Achilles tendon. And then this one up against the wall is specifically targeting that plantar fascia. So you can do all three. Moving on to Achilles tendinosis. I see some shaking heads. KD, ruptured his Achilles tendon. He said he had a calf injury. He didn't have a calf injury. It was Achilles tendon injury all along. And then he played heroically and ruptured his Achilles tendon. So there are lots of problems that can happen with the Achilles. It's a fairly avascular structure. It's large. It's the biggest tendon in the body, and it's attached to one of the biggest muscles in the body, and you're constantly on it. So there are lots of things that can go wrong with every element of the Achilles tendon. So tendinosis is the actual fascial thickening of the tendon itself. There are lots of micro tears, and that causes some inflammation and pain over time. There's actually new blood vessels and nerves that go to the site of the small ruptures, and that causes this lingering pain. They shouldn't be there. You shouldn't have much pain in your Achilles tendon. When you do rupture it, there's some discomfort, but it's not as painful as you might think. So there's also tendinitis. That's the early stage of tendinosis. You don't have to have subsequent tendinosis with tendinitis. There's peritendinitis. The Achilles tendon is not surrounded by a sheath. It's surrounded by peritoneum. That's where it gets all its blood supply. And you can just get irritation of that as well. And then, of course, a muscle strain is something that can go along with that. And then bursitis is the back of the heel where that Achilles tendon inserts. You've got an adventitial bursa between the Achilles tendon and the skin, and one between the bone and the Achilles tendon. Both of those can get irritated. And then a Haglund's deformity, that's something congenital that usually I see in my high-arched people. That's that proverbial pump bump or colloquial pump bump. And then ultimately you can see a rupture, and either that's preceded by some problems with the Achilles tendon and pain, or it can happen in isolation for no particular reason. So this is a type of problem that I see in healthcare workers. It's not usually a very, very high energy type injury. So it is something that I see. But fortunately, healthcare workers are not predominantly, but majority, there's a majority of women, and it's more likely to happen in men. So Achilles tendon exam, you see this burning and stabbing pain that gets better with warming up, a lot like the plantar fascia. I'm only going to go into the Achilles overuse stuff, not the rupture, because that's a whole other talk that I gave earlier this year. This is a piercing that I wouldn't recommend. This is overuse, inconsistent use on hard surfaces, direct trauma. I see this quite often in my healthcare workers. It runs right in the back of the Achilles tendon, bumps the back of the heel, and we get an acute injury. Medications can also cause some of these problems with the Achilles tendon steroids. Fluoroquinolones are notoriously bad for tendons in general. Poor MPJ mechanics, the problems with your big toe can go all the way up to your Achilles tendon because you're altering the way that you walk. Stiff ankles and hypercholesterolemia, that's a familial trait. That's what I see in a lot of these people who have spontaneous Achilles tendon ruptures. The picture on the left is a picture of Achilles tendinosis. That's that chronic thickening. This is what I see in the cases that kind of take a little longer to get better. This can take 6 months to a year of conservative care to get better, or we we can just go in and strip off all that extra blood supply and extra nerves that's not supposed to be there, and actually debride out the tendon that shouldn't be there and repair it up, and that's fairly well tolerated. The picture on the right is that bursitis, that pump sort of pain, and that can go away with conservative care as well, but sometimes we do have to do surgery to eliminate that bump and then restore the Achilles tendon to its normal location on the back of the heel. The picture on the right shows that adventitial bursa versus the retrocalcaneal bursa, and how both of them can be inflamed and be at risk of simple traction and pressure. Again, healthcare workers, you can see the same elements of the plantar fasciitis risk and then the stretchers. Achilles tendinitis, this fact is very important to understand, is that the one that I highlighted there. Number one, 24% of athletes will eventually have Achilles tendon injuries, so it's definitely like an overuse. You're using it, and that's how you're getting a problem with it. It's 2.5 to 59 injuries per 1,000 hours of running. However, in our elite runners, it's far less common, and they're running a lot more hours. So, what's going on here? It's 9% of recreational runners that are going to have a problem with this, and that goes right back to the inconsistent training and the overtraining aspect of things. So, and again, ruptures are 3.5 times more likely in men. So that's a take-home point for me from this lecture, is to stay active doing something. If you like to run, but you can't because of your job or because of other family things that are going on, do something. I just jump in place when I'm at the office because I like to run, but I can't always. So that keeps my Achilles tendons in check, keeps me awake, keeps that tendon able to respond to ballistic activity. Achilles tendonitis treatment. So again, I've got these two treatment arms, the acute and the chronic. So we talked a little bit about this. Eccentric loading. Eccentric loading is a very interesting technique that nobody ever does, even though I stress it every time in the office. But it's the most effective thing that you can possibly do for your Achilles tendons. Is you go up on two, down on the bad one. That's that eccentric loading, and you can go off a step, and if you get really good at it, you wear a weighted backpack, and you do them until you can't do them anymore, to exhaustion. And it does alleviate Achilles tendon pain better than surgery. I really don't think stretching is as important as that exercise. So that's why I'm saying plus or minus stretching. If you're tight, stretching helps. Rest does help. Non-steroidal anti-inflammatories, a heel lift to take a little bit of that tension away from the Achilles tendon, all of that does help. In the chronic setting, I still use eccentric loading. Sometimes injections, but I do not inject steroids into the Achilles tendon. You will get a rupture from that. I use either just straight up saline, I use local anesthetic, or I use a stem cell. In my case, it's usually an amniotic tissue allograft, which is covered by insurance now. This can also be helped with shockwave, which I don't use, but I'm growing. I have a growing trust in that treatment, and then surgical debridement. Prevention is kind of my thing with this. I think that everybody should be doing eccentric contractions in their daily routine, and then light ballistic exercise regularly. That's what I'm talking about. Just the light jumping, the light jumping jacks, something to keep those Achilles tendons from getting worn out and not being used properly, or overusing them when you want to use them. And then avoid repeated overexertions. Weight loss always helps. Smoking cessation is a big one. That's actually something I'm always shocked about with healthcare workers, is they smoke a lot. And I think it has to do with the stress involved with the job. And also there's a social aspect there too. You get to go outside and have a smoke with your friends. So wear supportive and cushioned shoes whenever possible. And I stress whenever possible there, because I know that sometimes you like to wear a nice shoe that's not so supportive and not so good for your feet. Ankle sprains, this is one of the most